So here we are at our monthly mastermind of the Insiders Group. I'm really thrilled that you're all joining us here tonight. And tonight we're going to be talking about CAMBRA and ethics. And the speaker is me, so to speak, with some assistance from my friends at Caries. And I'll talk more about that as we move forward. But let's get through some of the business basics. First of all, remember our masterminds are for continuing education. We are a PACE AGD provider, and this is our think tank. This is to learn from each other. So I want to hear from you all. Yeah, using the chat box is okay, but one of the things that we can really learn from each other when we hear you talk. So anyway, that'll be what we do. Now, what we're going to do to qualify for CE, we have to do two things. We have to have a course description, which I have, and I need you to write your name, both first name and last name, in the chat box. Now, we're going to double check it a couple of different ways because my trusty assistant, Patty, the other Patty, also has a list of the participants invited here. If you're here as a guest of somebody else and we might not have your name, then let us know. So are you guys having a hard time hearing me? Are we doing okay? Patty? We all right? All right, so let's move forward. You would get your course attendance verification and your CE hours right away. So the connection's going in and out. Huh? All right, you know what I'm going to do is I'm going to call in. Okay, so we're going to put a hold here for a second. So
Okay, I'm back. Is that better?
Just need to speak a lot louder, Patty.
Somebody talk to me.
Oh, now it's better.
Okay, all right, good. As long as it's better. All right, so anyway, your CE certificates you will get tonight or first thing tomorrow, and so you can keep track of it. I also want to tell you a little bit about some other things that are going on. But first, let's talk about who is here. Well, I'm here. So let's go down the list. Barbie Lynch, you're here, right? Say hi, Barbie. Barbie.
I'm here.
There she is. I knew she was here. Thanks for coming.
I'm here.
Cindy, Cindy, are you here? Cindy Purdy? I don't see her yet. Denise Snarsky, I think I saw you come in.
I am here.
There she is. There's our beautiful Denise voice. Jennifer. Jen, are you here yet? There
I am.
Yeah, excellent. Karen? Not yet. Kim Jackheim? Nope. We have another Kim, though, that I don't see on the sign-in list. I mean, it didn't say yes in advance, but Kim McElwee. How do you say your last name?
McElwee.
McElwee. Hey, it wasn't bad. Terrific. Linda Jorgensen.
Hi, everybody.
Hi, Linda. Angela Craig. Is Angela got the bark?
Yeah, no. I'm here.
Say hi, Angela.
Hello. I don't have
Hello. I also see an Angela Marshall. Say hi, Angela.
Hey.
Terrific. Glad you're here. And Cheryl, say hi again. You were here. We say hi. We said aloha from Hawaii, but say hi again.
Hello, everyone. Thanks for putting this on, Patty.
Thank you. I see Bree. Hey, Bree, put your last name in next time, okay? Patty's got to find you on the list for us to give you CE. Say hi, Bree. Bree. Now she's the microphone's off. Okay, Jan Palmer.
Hello.
There she is. Hi, Jan.
Hi, Patty.
Time. Hey, it was great to see you spend some time at the airport together, since that's where I spent half my life lately. So,
It was great.
and
Who's
Joy, are you here yet, Joy?
Who's chopping in the background? It's hard to hear.
Yeah, if you got any extraneous noise, can you please, mute your mic until we ask Jill, do you want to talk? Okay. That's what Bree said. She's got a noisy 4-year-old. So, Joy is not here yet. Joy has agreed, though. I had the joy of meeting Joy when I was in Virginia, and she's going to be doing one of our masterminds coming up over the summer. Kathy Fowler, I think she said yes, and then she told me that she couldn't come. How about Laurel? Are you here yet, Laurel? No? Okay. Michelle? Not yet? All right. Come on, slide change. Next we have Pam. Are you here, Pam? Nope, not yet. Patty, now let's talk about this name, Patty. So you're a P-A-T-T-Y, but it comes up Patty Mills versus Patty Korecki. Which is your name? Patty. Patty. She was there. I don't know what happened. All right. Sandra Berger? Not yet.
It's Patty Korecki.
There she is. Hi, Patty. It's Patty Korecki. Okay. So when it comes up Patty Mills you go by Patty Korecki. Got it. All right. Sue Patton. Say hi, Sue.
Hi, Patty. I'm here.
Terrific. Happy Oral Cancer Month. I don't know if happy's the right term, but anyway, it's your month, girlfriend. Val Danver, I contacted me, and she told me she couldn't make it, but she's going to listen to the tape, and we'll talk about that. Again, we've got definitely some noise in the background there. Patty B, say hi, Patty B.
Hi.
There she is. Rhoda?
Hi, Patty. Hi. Hello. Yes.
Rosalie?
Good to hear you. Hello, I'm here.
That's terrific. We're so glad you're here, Rosalie. And then we also, Susie Brzezinski here yet? No? Teresa Shepard? Not yet. Catherine? Catherine Sulu? You here?
Yes, I am. Thank you.
Terrific. So glad you're here. Ever since I have your name spelled right, I really like when you come. I always liked it before. I figured out how to spell your name right.
I appreciate that.
Lisa, yeah, how are you, Lisa?
I'm good, Patty. How are you? Hi, everyone.
And it's great to have you. Michelle Race, I see you there, my New Yorker friend.
Yes, I'm here. Hi, all.
Hi there. Nancy Brohan, Delaware. How you doing, girlfriend?
Hello. I'm good. How are you?
We're good. Diana Corbin, I don't see Diana yet. Thank you. So she signed up later. But Noelle Paschke, I did see you.
Yes, I am here.
There she is. We also have 2 special guests, and in the tradition of the Patty, we have Jenny. We have Jenny Tegner, who is a hygienist at Dr. Carson Cooch's office, and I'll explain more about who Dr. Cooch is in a bit. But we also have from Caries Free, Jenny Wolfenbarger. Say hi, Jenny. Come on, let's hear she got hi y'all in the box. Come on, let's hear your voice, my dear. I may need to call on you.
Jenny Tegner or Jenny Wolfenbarger?
Yes, all of either one. Oh, Jenny Wolfenbarger doesn't have a mic, but Jenny, we're really glad you have the mic then. Jenny Tegner. Good. Thank you again all for being here. We're going to have some good discussion tonight because this is a subject to which I am personally passionate. But before we get into the meat of what we're going to do, let's talk about our Dental Podologist Consortium. First, I want to talk about where we are in a wonderfully shifting group in that you're all insiders. And we used to have a separate group for the DCC, which are people that chose to be on the committee to work on codes. Well, guess what? We decided all of you are on that committee. And if you can make it, great. You make it sometimes great if you can't make it. But you'll be getting the evites for our consortium meeting. We did need to change it this week, which thank goodness we're supposed to have it on the 7th, I think. And not only did I not get home by 7:30 at night that I was supposed to, or 11 o'clock the second time, but Patty and I got off our plane to finally home about 3:45 in the morning. morning. So it's a good thing we pushed our meeting. So our next meeting is on Sunday the 28th at 7 p.m. Central, and we will again send out the Evite for you. It's a really, really important meeting for us to talk about what the results were for at the Code Committee on March 14th, as well as to begin planning our submissions. Even though it feels like, oh my gosh, we just got done, we got to start again. Yeah, it's an ongoing thing. In order to get the submissions in the timely manner, they have to be submitted by November 1st. And in our learning over these 2 years of submitting codes ourselves, it's all about coalition building. Well, we can't start building a coalition if we don't get our code submissions done until late in the year. So we want to get our code submissions done and start building the coalitions as soon as possible. So we start planning partly based on the results of what happened in the year before. Now, what's also happened is in the middle of a beautiful transition, I lost my web guy. So I've been working on trying to keep things up myself. I do want to show you though, if you're looking ahead for what the schedule for these meetings are, I'm live on the internet now. This is the calendar. It's at downcodeology.com, and you will see there's tonight's mastermind. The one thing I want to point out though is Sunday is on the right. It's a weird calendar, but that's what we have. So there's the mastermind, there's the consortium. So if you want to look ahead and put dates on your calendar, that is probably the easiest way to do it. And what happens is even if you hover over it, it'll tell you what the meeting is about as well as the time. So that's how you find out what's going on. We're changing how we're doing our newsletter too, so that's the easiest way right now. Our next mastermind will be on Monday. Again, we change it from Monday, Tuesday, and Wednesday, and we go from 6 to 7 to 8, depending on the time, because we try to make it as friendly as possible for as many time zones as we can. And again, I want to say thank you to our Eastern friends, who it is almost 9:15 at night. But yet we also like to have an opportunity for our people from all across the country. So that's why we switched the times up. Next time it's Insider Anne Marie De Palma, and how many letters does she have after her name, because she's quite accomplished as well as being a terrific speaker, and she has been working in the technology end, and so we're going to talk about technology and HIPAA and where things are in our current world. I do want to mention too is insiders content. The insiders content, if you can't be at a whole meeting of this, or you want to go back and look, this is part of your benefit of your membership. Again, I'm going to go back live to the website. And in this insider section, mastermind replays, here's all the masterminds. Now, the masterminds also, I'm going to connect it to my system for doing quizzes. So if you can't be on a mastermind, you can listen to the mastermind, answer 5 little quick, easy questions, and you can get continuing education credit for ones that we've already had. So that's another benefit if you can't make them or you want to go back and re-listen to them. So again, to qualify for CE, we need both your course description, what we have, as well as your name in the chat box, your first and last name. I have all of your email addresses, obviously, because that's how I got a hold of you in the first place. So here we are. CAMBRA and ethics in dentistry. Well, one of the trips that Patty and I were on, our long trip, was we were first in Miami to speak. I had an opportunity, I was invited to speak at the Medical Professional Liability Association. Basically, it's the malpractice carriers. They invited me because of the work I've been doing in the teledentistry realm to come and talk to the malpractice carriers about what they might need to do to make sure that all professionals are insured properly for anything that might come up in a teledentistry situation. It was quite an interesting audience down in Florida, because it was 4 dentists and the rest were either insurance underwriters or lawyers. Very different. And then what we did is we got on a plane and we flew from there via Dallas all the way to beautiful Oregon. and Oregon, we were picked up at the airport by our friends at Caries and brought down to their beautiful facilities in Albany. It's about an hour and a half, are we south? I think south of Portland. And we got to see their facilities and had an awesome year. Thank you again, Jenny. We'll come back anytime and go to that restaurant. Anyway, and with that, what we were talking about is with this, is the whole derivation of Carie-free, CAMBRA, and this presentation, well, we thought about maybe having somebody from their group do it, but instead we have our wonderful Jenny Tegner, who's a hygienist for Dr. Carson Cooch, who is also, is the office in Albany, Jenny?
But yes, Albany.
Yes, okay. And you've been working with Dr. Cooch for how long?
8 years.
8 years. 8 years. And how long have you been practicing?
8 years.
8 years. So have you all in that same wonderful practice?
Yeah, I mean, I was a assistant before, and I worked front office. But as a hygienist, I've been a hygienist for 8 years. So I was working front office at Kim Cooch's office, and that's how Carson and I met. So then when I got my hygiene license, he hired me.
So you've breathed some pretty good rarefied air here all along in your career, haven't you?
Yes.
Yes. And it's, for the rest of you that don't know, Dr. Kim Cooch is one of the very foundational people when it comes to CAMBRA, Caries Management by Risk Assessment. When you read, especially back in the beginning days, when you read a lot of the papers, you'll see Dr. Cooch's name as well as Doug Young, John Featherstone, many of those. This is a book that Kim wrote with his son-in-law back a couple of years. It is the book for all of you to have when it comes to all things CAMBRA. And what you can do is you can contact, and I'll give you some contact information in a second, Caries, and they'll send you a copy if you don't have a copy already. It's the book on it. It's just, it's amazing how much it shifts our paradigm. As a matter of fact, it was really interesting. I got Patty sent me something earlier today, and then I had a article that I saw on Dr. Bicuspid today that was exactly about the subject that we're talking about tonight, CAMBRA. Caries Management by Risk Assessment. What does it really mean? Well, again, there's a picture of Dr. Cooch. He just did a webinar last week, and he is an amazing speaker. So if you ever get a chance to hear him present, it's in person or via webinar or whatever, listen. His scientific mind is amazing, and I'm sure Kim can speak to that even more. And during that that update, he brought forward a lot of the most recent information on the connection between caries and just lots of research. And I'm going to talk a little bit about it in a second. But before we do that, we're going to do something different. We're going to talk about, pathogenic, we talk about pathogens, we talk about biofilms. We mostly, especially as hygienists, can fall into the realm of thinking about perio. But when we talk about teeth, it's teeth wounds that are also from a pathogenic biofilm. And by the time they have the wound or the hole, the disease is pretty far along the continuum. And again, Caries Management by Risk Assessment, CAMBRA, is that different approach. It's a different paradigm, and that's what the article I was reading was talking about. Now, I've used the word paradigm for a long time. Matter of fact, I first heard the word almost 30 years ago, and I thought it was two coins, two dimes of paradigms. Okay, I didn't say I was that smart. But anyway, and then I saw it spelled P-A-R-A-D-I-G-M, and I thought that spells paradigm. But the thing is that a paradigm is not a product. It's not a procedure. It's a philosophy. It's a philosophy, in this case, that gives us an evidence-based framework for what we do. An awful lot of what we do in this clinical practice is not based on science. It's based on tradition. So what we're going to do is we're going to do a live poll. Now, I'm using my cell phone, so it'll be a little challenging. But if you've ever been to course with me, you might have done this. What I want you to do is get your phone, and I want you to get a text screen up. And the number you're going to text to, as it shows there, is 22333. In the body of the text, you're going to write the word gingivitis. And just in case you don't know how to spell that, it's spelled there for you. Ha-ha. So 22333, gingivitis. And it'll show up again. what we're going to do is we're going to answer this question: is how many of you are routinely doing risk assessment in your practice? A, B, or C, that's the answers, okay? But in order to get this to play, I'm going to go live to the internet, she says with open her voice. Come on, baby. Okay. Always works in rehearsal. So again, 22333, and hopefully when this comes over, we will see how many of you have already voted.
Mine says the poll isn't open. Maybe I sent it too early.
That's right, you'll get it if you...
Second one works.
Come on, activate poll.
Nope. It says it's not open.
I had it open before. I'm working on it now. There we go. There we go. Okay. And then as you see the numbers, see the responses. So we get so far what our response rate shows. I mean, hey, that's a pretty cool slide, right? So it shows that this group here is 50% of us are routinely doing risk assessment. Is that an accurate statement? What do you think?
No.
Anybody? No. Why not? Why not? Why isn't that an accurate statement? Come on, somebody. Mastermind, let's talk. Why is it
Well,
not an accurate statement?
We don't have a big enough poll group here.
How do we know, what do you mean, what's a big enough poll group? What does that mean? Hello? Who said that?
I did. Susan. Yeah, we don't,
Susan.
well, there's not enough people here to really get a good assessment, you know, of
assessment of what though? What are we trying to assess, Susan?
Assess who is actually doing the CAMBRA assessment.
Right, but correct. Is that the question?
Pardon?
Was that the question? And thank you for letting me put you on the spot this way.
Well, evidently it wasn't, so.
Well, no, because it says how many are routinely doing risk assessment, okay? What does risk assessment mean? I use polling in my courses a lot because this is such a great exercise, because the thing is that each of us can read that question differently. How a question worded is very important in any research study. I use this as much of for the answer that we might get here as a discussion of evidence-based decision making. First of all, and this doesn't really make a difference in group size in this particular thing. No, it doesn't. But here's what really all I can say is that 46% of you that answered yes. That's all I can really say. And I can say 31% of you that answered said no. And some of you, 23%, said sometimes, except when I set up this poll, I set it up that you could answer more than once. Now, you may not have, but how a study is set up, how a poll is set up, what were my controls on this trial? Oh, I didn't have any. I didn't have any, did I?
Mm-hmm.
You could have answered, you could have lied. The reason that this is important is because a lot of times, especially when people are teaching science or evidence or whatever, they'll throw up a slide and this is what this shows. What this shows is that 46% of the people that answered said yes. That's all it shows. Who created this slide? Well, I created the background, but all of us together created this slide. What the message for me to you is that when we're looking at science or when we're looking at someone's slides or when we're being presented information, we need to be very clear on what we're looking at, what the setup was for it, what's the control for it, and potentially, let me go back to a regular screen. We have, how many people do we assign? We have 26 people that are online. Of those 26, I don't know how many answered. I have no idea. I don't have any conclusions on that. But it looks like we can still say, well, just under half of us are doing some type of risk assessment routinely. I'm going to guess, though, it's probably 100% of us are doing some kind of risk assessment, because isn't a review of a health history a risk assessment? Isn't a review of their medications a risk assessment? Yeah, it's interesting when we use that term, risk assessment. What does it really mean? Now, if you look at your phone, you will see on your phone, first of all, it was a permission-based thing, and we don't keep your information that you texted in. But on your phone, you now have, on your phone, so you don't have to remember or do this right away, this number. If you want to do a webinar with Caries free, you can text the information to that number later, and they'll do a webinar for you. Tricky, huh? How's that for some fancy technology? So, moving on to what Dr. Cooch said about Caries update. This conclusion, this is from a study that came out just last November, and what it says, Caries significantly increases in people with cognitive impairment. Okay, we probably know that. Dental-related function mediated the association between cognitive impairment and oral hygiene. It accounted for 80% of the total impact. The thing is to go the other way. Because cognitive impairment can affect the caries risk, increase it, but does caries risk increase have an effect on the brain? And the answer is, yeah, it does. We know that. There is a connection between cognitive impairment and dental caries. That's why the way the dentistry has called it, oh, just a little cavity, oh, it's just one cavity, is just such a, you know what? I think it's almost a crime. Why? Because it's just a hole in your body that we're going to surgically treat. And the thing is that when we don't deal with the causes of the disease process, it's going to go on and on. Cognitive impairment. Oh, Carson himself is here. This is another. What?
It's me. It's Jenny Tegner.
Oh, it's Jenny. Okay, you got that. Okay. Okay. This is actually a research that just came out in 2019. And this is one, I did see this on a few of the headlines, and it's the connection between colorectal cancer and mutations of some of the same microbes that we have in oral biofilm, that the oral biofilm can negatively be a cancer facilitator. Now, I look at that and I go, oh my gosh. Why? Because when it comes to risk assessment, I have my father and 5 of his siblings have already had colon cancer. So we already know that we're at high risk. We've done the testing for genetic testing, and now we know I carry a gene for colon cancer. And I have, well, for me, I started with my baseline colonoscopies as recommended at age 40 or whatever. Well, what about my 29-year-old, almost 30-year-old son? Do we wait till he's 40? Now let's add a caries infection situation on top of that. This is where it adds up. Did you also not hear me say that, just tell you all kinds of information, all kinds of risks that I have for head and neck oral cancers? Yeah, all in this same family. Risk assessment is not just a procedure or a time, it's about listening. It's about listening and putting together the clues and the pieces and the parts that people share with us. So this connection between colorectal cancer is very important. Before we go on the next one, Patty, would you talk about the article that you sent to me earlier today? Because what they were talking about in that article is right in the same realm, correct?
Oh, thanks.
What?
Sure. They were actually talking about the inflammatory process and how the immune system actually affects decay. If I remember correctly, and this is a study that came out of Canada, by the way, and Shirley Gutkowski posted it today, and I saw it and I read it, and that's when I sent it to Patty. It was this afternoon sometime. But it had to do with the neutrophils, and the neutrophils actually destroy. Wait, let me back up. It had to do with decay and the composite restorations that are being used, and how the neutrophils actually help to destroy the composite restorations as part of the process that goes on in the oral cavity, which explains in part, or could explain in part, why people who have those have to have them replaced so often, and why we see recurrent decay around them. I was fascinated.
But actually, the action of the immune system itself that's trying to create some balance, in other words, to get rid of what it sees as the foreign invader. But part of that healing process also causes damage. Is that what you're saying?
Mm-hmm. Yeah.
It's
actually activating more decay. It was, you have to see it. I was fascinated. I read it once and I sent it to Patty, and I didn't know I was really talking about it, so I didn't read it again. I apologize, but it is a fascinating article to think that this is what's happening. And the little that I know about resins, I'm learning more. The different components in them, I don't know how these neutrophils do this, but I'm fascinated by it, and how the immune system is actually causing more decay. I can't wait to see more.
And really what our message in an awful lot of this is just that it's what we think we know about the Caries infectious process is not necessarily what we know from current science. I know with Dr. Kuchin, when I've heard him talk before, we like to give it, talk about specific bacteria, and that's not the way it works in the mouth. We know we have biofilms, and those biofilms are different than the individual species that we have. And our goal is actually to create a healthy biofilm. And that's, again, so contrary to the way most of our training and education has been. And then, of course, there's the breakthroughs of SDF. Now, I tease Connie Simmons, one of our wonderful insiders here, because Connie, tell them what you're doing and what you've been doing for the last 9 days.
Well, I happily accepted a position with Elevate Oral Care, and I have been training. I trained in West Palm Beach last week, and now this week I have been Saturday, Sunday, Monday, Tuesday, I was in Austin co-traveling, and today and tomorrow I am in Mission Viejo, California co-traveling. So I am absorbing everything, and next week I start my territory in New Jersey. I could not be more thrilled with everything that this company is about, everything that we're changing lives. SDF is changing lives, and I'm so happy to be on the forefront of what we're doing. So this is one of our best slides, so thank you for putting it in there, Patty.
And one of the things I want to point out here is Jeremy Horst down here is basically the father of all this stuff with silver diamond chloride. And what we're talking about is having to we can arrest Caries with that. I know some of you are already using it here, but what they're talking about is it creates silver micro wires within the plaque biofilm, and it affects the microbiome. 38% of the silver diamond fluoride applications are on exposed roots, and again, for older adults, which I define as older than me, but it is a fast, simple, inexpensive way to deal with these, especially when we've got the recurrent root caries in some of the older adults. Look at that picture. This is an actual case, and actually, too, there is Doug Young, and this is Dr. Wong. He's the one that came to our DCC group, and we worked with the CAMBRA coalition to help get a code through. Anyway, this is a case of somebody that has extreme high caries. When I first looked at this, I'm like, is that tooth? Yeah. This is somebody with Sjogren's, and so this is what's happened to this individual's teeth. So can we do a whole bunch of crown and bridge and all kinds of the fancy stuff that dentistry's been doing for a long time? Yes, we can. Is that the best choice? Well, the choice of the practitioners was to use silver diamine fluoride with glass ionomer. So you ready for what this looks like after? There it is. That's what silver diamine fluoride looks like in any active areas. Connie, you want to jump in on this a little bit? Talk about the black thing.
Sure. So most people assume that silver diamine is what turns teeth black. I mean, they say, my patient's not going to want a black tooth. Well, as you can see in this picture, the only thing that turns dark, the silver oxidizes the collagen, and that's what turns dark. So the few little white places that you see left
This person has
are the only areas in this individual that did not have active decay going on. So it does not stain healthy dentin or healthy enamel. So don't be afraid to use it on healthy tooth structure. It is a great preventive thing that we can start using as well, not just treatment. But I can talk all day on it because it's been drilled in my head for so long. But I'll let you get back to your presentation.
And as you can see in this bottom picture, then they use the glass ionomer to really, I mean, look at this, look at the difference for this person. Wow. Wow. Plus we arrested the breakdown and talk about, you know, again, the aesthetics are so much better. Now we can look at that as clinicians and go, well, that's not very good aesthetics. Yeah, it is. It's really pretty tremendous aesthetics that we have here for the patient. And as Connie just said, the blackening of the lesions, yeah, that might be a downside, but is it? Or is it really just showing exactly where the decay has been? And we do have the things that we can add to it. And this would be called, actually, this is called a smart restoration. What? We have an arresting product, and then we have a glass ionomer product, and that's called a smart restoration. There's different things that people talk about with using the technologies, and it also comes to coding. What's really interesting about this statement is exactly that. Whether or not this product makes an impact on the profession at large really depends on dentists and hygienists understanding these indications and limitations and documenting its use and patient exceptions. In my opinion, it's a tool every clinician should have available. I hope you do have SDF available to you because, again, it can make a significant impact in many populations. Thing is what about the codes? Well, let me 101 with codes. Okay, there's the sealant code, then we have the sealant repair code. Sealant repair code was added a couple of years ago. This is the code that actually was company Elevate that came to the coding committee and they lobbied or they submitted to have a code for SDF. But here's the thing about codes. Codes are not product specific. So this is written in such a way that other products, it might come under that definition at a later time. An example is that the code that we have for adjunctive oral cancer screening, adjunctive technologies, when it was first created by the coding committee, the only product available was Visalite. But since that time, we have the many other ones. We have the Delscope and we have the Oral ID. We have the other products. Same thing might happen in this because that's the way codes are written. They're written more generally. The other thing about this code is when it came out a couple years ago, it did not have a per tooth part of the definition. And that was again brought forward by the Pediatric Dental Association to the code committee because they wanted it to become a per tooth code. Now, codes are really important to use. Accurate codes are important on a bunch of levels, and we'll talk about that in a second. But this one is really interesting, and this is where codes really come in. Assessing the validity of existing sealants and measures. So this was a study that was done, again, it came out last year, as you can see in September. And what this was is it was measured by the Dental Quality Alliance as well as the Oregon Health Authority, which rely mainly on CDT procedure codes. And it really can be, I don't know, is it estimation, underestimation? Or do you think the truth is that we're only using sealants 18.5% of the time? Wow. That's the power and the importance of coding. That's why the dental codology brand exists as it does. It's important for we clinicians to know codes for three important reasons. Yes, there is the third-party payment, which is what most of us think that's the most important part. It is not. It is not. It is just one of three parts. Another reason why we clinicians need to know codes is because HIPAA designated in 2001 that CDT is the standard code set for electronic health records. What that means is in your electronic health records, in your practice, you must be using the most accurate code to describe. Somebody got a dog? Can you mute whoever that is that's got the dog? Can we mute your thank you. You need to use the most accurate code available in your electronic health record. If an anchor code exists, you should be using it. And third-party reimbursement should have nothing to do about whether a code is used or not. It's to describe the treatment and the procedures that we're doing. These are procedure codes. They're not insurance codes. They're procedure codes. And then the really important one, as we just saw in that last study, is the metric that they represent. Codes represent important metrics. We need to move our healthcare system from one that, if the sicker people are, the more treatment they get, to one that's a wellness, outcome-based, and metrics and measurement is really an important part of that. This is another piece of research that just came out again late last year. Validated risk assessment strategies such as Caries risk assessment model allow dental providers to implement systematic and evidence-based approach to astutely assess and record changes in their Caries status of patients with an effort to prevent disease. Yeah, it's about Caries risk assessment. Now, this particular form is the form from Carie Free. There are forms that you can get from the CAMBRA Coalition. There's forms that you can get from ADA has their forms. I'm going to be honest, I think the ADA forms are a little too disease-oriented for my case, but you should, you can do this as a paper and pencil, or you can do this at pencil, did I say pencil? Or an electronic form. But this is to me, one of the very, very important steps. Now, if you've never used these forms, these aren't something you give to the patient. These are something you use with the patient. Here's the results of that research. Only 14% of patients are currently using a Caries risk assessment in their practice. So this group at 43% by your own report, higher than the average, isn't it? 14%, it's lack of patient transparency. In other words, are the patients even telling the truth? It does take additional time. You know what, though? Let's talk to Jenny. Jenny, talk to me. How are you using the CRA form in your practice? What's your protocol for how you're using it?
So what we do is we are alternating patients' cleanings, whether we're doing x-rays or pericharting, an oral cancer screening exam. So if it's a day that they get x-rays, we automatically, that's the day that we do the Caries risk assessment. And so we will take the swab, which I know we haven't gone over yet, but we'll take a swab, and then we have an auto note. So if whatever the number comes up, we have an auto note that will prompt us to ask the questions that are on that form. So we actually do it all electronically. We don't, I mean, we have like a master sheet, but everything is done on the computer. So it just prompts us, and then we'll ask the patients the questions, and so then we just document it right there in the notes.
And what's your experience with it with your patients?
It's good. You know, it definitely puts more of the responsibility on them as far as their interest in it, what their number is, and then an interest in figuring out where that risk is coming from, which the questions are prompting us to kind of be able to come up with that, where the risk is coming from. And then they're definitely more agreeable to change habits, behaviors with that information, because it's not just us guessing on where it's coming from or assuming we know where it's coming from. It actually, you know, helps guide us to really figure out where their biggest risk is.
Now, what you mentioned already is the Caries screen monitor, which I didn't put a picture in here of the monitor. I love having that monitor with me on courses because we do it live. But talk a little bit about what the Caries screen monitor is and how you utilize that in conjunction with the CRA form.
Yeah, so it's a handheld, or you can get a little. Ours rests on a little plastic thing, but so it counts down 60 to 0. So we'll usually press that right before we take the X-rays, so that by the time we're done taking the X-rays, it's ready to go. And then we will take a swab, and it's just on the inside of the lower anterior teeth, and we just have to make sure that we're not getting any of their gingiva or lip or anything like that. And so we'll take that swab. You need like 6 teeth, and then we put the cap back on, and then we break a solution that's connected to it. shake it, and then we put it into the monitor, and then it takes 15 seconds to read. So something that can be really powerful is to actually have the patient hold the monitor while it's counting down, so that, you know, they're wanting to see what the number is or what we got. And then based on what the number is, whether they're low risk, moderate, or high, then we can talk to them about that. And then if it's moderate or high is when we will do our auto note and start asking them questions, you know, about home care, medications, diet, and things like that. So, and then from asking them those questions, we can usually get a good idea of where their biggest risk is coming from.
Yeah, I use the Caries screen in my courses, and often it's, you know, 3 hygienists, and and I'll tell them, you know, if it's below 1,500, that's okay, but if it's higher than 1,500, that's when we have concern. And then it happens, I can tell you, it just happened in Oregon, and we had somebody, a hygienist had 6,000, her score was over 6,000, and then the second one, as soon as I started having her swap, the third one started to come up with all the excuses, okay, of all the reasons why it's high, all the reasons. And I believe we had, one was like 6,500, one was 8,300, one was like 12,000 something. The thing is, when we talk about having a number like that, right away, what should I do? I'm like, oh, I don't know. That's a single point of data. It's not we don't make decisions from a single point of data, but that data being a number is huge. Because should we treat somebody that's got a 6,000, 8,000, and 12,000 all the same? No, we need to figure out what's going on. And that's what the power of using these different diagnostics and different, well, Caries risk assessments. Now, of the 43% of you, are you using these codes? These codes, I have the word modifier underlined on purpose. Modifier is not a word that ADA uses. It's not a word that the codes committee likes. They don't want to have modifier codes. Anyway, but these are what I call modifier codes. What that means is they're codes that you use to support other care that you're doing. Because if you're using a recognized assessment tool, that's, if you look at that's the definition for all 3 of them, it should be documented. It should also be documented what risk assessment tool that you were doing to determine that risk. But the power of that number, the power of using these codes together, this helps optimize anything under the third-party reimbursement, but it even better identifies what we're dealing with and what way we can. Now, let me ask a question, and this is out to the general audience. First of all, if you're using these codes, great, talk about that. If you're not using these codes, talk to everybody about the why. So who wants to go first? Because I'll call on you.
So Patty, I can give a little bit of insight of what I've kind of found in the past 4 days co-traveling, talking to, because it's a big part of what we educate on when we go in and talk to offices with Elevate. So what I found a little bit discerning to me in the offices where they accept Medicaid, and Medicaid, or whatever their version of Medicaid is called, if they require them to do that in order to pay for silver diamine fluoride or to pay for an extra fluoride treatment, I had three offices say outright, yeah, we only do it in our Medicaid patients. And
they only do Caries risk assessment, or they only use the code, or both?
They only do the risk assessments on the Medicaid patients. And
well, that's interesting.
Yeah, and so I said, well, that sucks for patients who have regular insurance. You don't care about their risk assessment? And it was all for them so they could get that additional reimbursement. But I came back in and talked to the hygienist after the fact, and I said, how is that good health care for your practice in general? You're missing the point of the risk assessment. And they said, you know, we just had this conversation with our employer last week, and I said, guys, we have to do it for everyone every time. That's our responsibility. So hopefully I made a difference, at least in that one practice. But I heard that in 3 different offices out of maybe 25, that they only did it when they had to do it, which is sad.
Okay. What other experiences? Any other practices? I have your names. I'll call on you. Who's using these codes?
Hey Patty, this is Denise Narsky. I have a quick
Hi,
thing
Denise.
that I just want to comment on the last discussion we just had about that. When you're in an office, if you're not consistent, and let's say Mrs. Jones has Medicaid, but her neighbor does not, and they have the discussion amongst each other, and they actually say to each other, hey, when you go to the office, did they do that risk assessment on you? That's discrimination. And those offices could be in a lot of trouble because they're not being consistent across the board with every patient that they have based on the fact that they're not going to get paid. So I just thought I would make a mention of that. I've had some offices go through some trouble with that.
Ooh, good point, Denise. Good point. Anybody else? Comments on the Caries risk assessment codes? Why or why not? Are they being used? Are they not being used? If they're not, why not? Who is it?
This is Bree.
Hey, Bree.
So I actually temp primarily, and I have several offices that I'm a regular temp in, so I see quite the gambit. One of my offices, I actually got scolded for walking out adjunctive codes and oral hygiene instruction. And was told not to do it. And then when I continued to do it, the front desk was instructed to just delete those codes before they walked them out.
Wow.
So as a clinician, not having full control over what is actually walked out in a practice can be a big challenge as to what's coded. Because I don't get final say on what is actually coded under my name.
Did you ask about the why of that?
I did, and they said they want all of their hygienists doing things the same. And I said, so do you not want your hygienist doing oral hygiene instruction? Well, they do. They put it in their note. I said, but we have to code what we do. And they said, well, we want everyone on the same page, and we don't do that. It's just more work. And I said, well, it doesn't submit to insurance, and it's $0. So I'm not understanding how it's more work. and the answer I got was, well, we just don't do that here. And this was a practice that also we polish on all patients, and we give a pre-med to all patients. And I'm like, okay.
They give pre-med to all patients, did you just say?
Right. I told a patient he may no longer need a pre-med, and I was told we give pre-meds to all patients. And I was like, all patients? And they were like, well, you know what I mean, all patients that need one. And I'm like, so infective endocarditis? And they're like, no, everyone who's had a joint replacement. And I'm like, but they no longer need one. So it's a real stream out there in the temping world. But as a provider, not having control over what's actually coded and in my name is the real challenge, because as soon as I walk that patient out to the front, they can change things in the account easily, change things in the account, change what's in the ledger, and I have no control over that. Oftentimes I don't have security permissions in the practice management to even change it after the fact, if I were to even be back there or see it after the fact.
Wow. Wow.
Uh-huh.
Oh, who wants to follow that? Gosh.
Yeah. It's fine out there.
So who else? You know what? I'm gonna go to Nancy Brohan. Nancy Brohan, you have been in your office probably longer than anybody else on this call. Nancy, you there? Nancy. Wake up, Nancy. She's not answering. All right. Let me go to somebody else. How about you, Michelle? How about in New York? How are you guys doing on using risk assessment codes in your practices up there?
Well, right now I'm in a specialty office for perio and implant. And of course, we don't do Caries risk assessment, but we do check for Caries and write it into, the letter to the referring doctor if there's anything that we actually see. But we do mention caries free to the patient if we see something, or that it's something for them to look into if they have a lot of root caries, or something. So that does get mentioned, but it being in a especially office, it's not our thing.
Okay.
But when I worked in general, we didn't have a form either, though. We did it just by the seat of our pants.
How about any other technologies? What about like using the Soper Care or a Spectra or any of those other risk, again, recognized caries risk assessment modalities? Anybody using any of those things on a regular basis?
This is Jennifer Zbarschek. Yeah, I have the CAMBRA. I like it. And I use it all the time. And we do all of the different risk assessments besides caries, OSA, perio, CVD. And we do plaque slides with the scope as well.
Mm-hmm.
And we code all of that too.
And you code all of that. Yeah. And you get pushback from the insurance carriers on coding. You ever heard me do that?
Yeah, sometimes. Still do it.
Yeah. Somebody say something? Because what I've heard from people, it's like, well, you know what, if you're going to put a code down, you have to have a fee that goes with it. Because if you put a fee down and it goes to the carrier and it averages in, and it's all these excuses about why we don't use the codes. But we really miss a lot of the metrics without using the codes. So let's go to the next question, which is really my purpose of this to really open it up to, are we ethically obligated to use CAMBRA methods? What do you think? Barbie Lynch, what do you think? Barbie. Hello? Come on, you guys all talked in the beginning. I heard you. There she is.
Yes.
Yeah. I had to unmute myself, and I have a new computer, so.
Okay.
In a perfect world, yes. I've never worked in a perfect office, and no one I've worked for has ever, to do this. And having asked about using codes on different things, I get the same thing. We just don't do that. And I don't know the age of my dentist that I work for, but I would say in a perfect world, yes, because we're there for the patients to protect them from the progression of disease. So.
Yeah, thank you. Andrew Craig, what do you think?
I thought it was interesting you were talking about the insurance aspect of it, because I started using it when our office went through an insurance audit, and the only thing that the gentleman said, he came to me and said, most offices around here are using CAMBRA, and it would probably be a really good idea for you to do that too. And that was a nice, gentle way. I would say we have a lot of the same information as talking about diet and high caries risk and all that, but it wasn't in a format as far as the form. And the other thing I'd say is I've seen on a lot of the public health forums that at the FQHCs and all those places, they do it, and they don't get paid if they don't do it. But it seems like from the conversations from the doctors, they are talking about it, the public health dentists, because they care, because they want to do it right. So that's my take on it.
Great, thank you.
Patty, this is Connie. I have a question for anyone who's listening. So who has heard, so what I have heard over the last 2 weeks is, as we move, closer to this paradigm shift that we're all in and working towards so hardly to get this uniformity between medical and dental and everything else that we're trying to do. But there are going to be insurance, third-party private insurance companies that are going to start paying based on us using these assessment codes, based on us, if we have reported every time that this patient is a moderate to severe, to high caries risk patient, they're going to have stuff built into their insurance plans where those patients are going to get additional benefits based on that. So I just wanted to see if anyone else had any information, any additional information on that as well.
I think it's interesting. I think that one of the things that I think that there is certainly more opportunity for the carriers to help push us, and that's unfortunately what I've seen is, unless we have to, we're not going to. Although, again, ethically obligated is certainly something that's different than you have to. Because where are the lines between how we get paid and what's our business and what's ethical? And when we talk about ethical care, is it ethically appropriate to do one-size-fits-all, that everybody gets what Bree was saying there, everybody gets this, everybody gets that, everybody gets everything? It doesn't make sense. It doesn't make sense from so many ways. It doesn't make sense to over-treat, because I think we're just as guilty of going too far the other way for some people. Does everybody need a prophy every 6 months? And does everybody need fluoride every 6 months? And that's the default the other way. So I think that what we're talking about here is really treating the person, because that's what they come to us for. They trust us. When they sit down in our chair, they already trust us. So are we obligated to use, because what CAMBRA is really, it's the science of what we know about caries, the caries infectious process. And that's the other thing, too, in my opinion, is that we need to fix our language. We use the word cavity and caries interchangeably, and they're really not. One is the outcome of the infectious process. The caries is the infection. Caries infection is the process. Cavity is the outcome. Fixing the outcome doesn't get rid of the process. So this is a really deep question for us to really consider. And so then we're in these places where maybe it's not as accepted, or they're not up to speed. So what do we do there? Well, that's all of us choose to be whatever practitioner that we want to be every day within the boundaries of where we are. I worked in one practice that I was paperless in 1992, and then I worked on the other end of the spectrum where they did everything the same for the 35 years they were in practice. They never changed a thing. Oh yeah, that was really quite an experience. But why did I work there? Because I could decide what kind of professional I'm going to be. This is not easy stuff, and that's you guys are the best of the best. That's why you're sitting on a phone call at 7, 8, 9, unless you're in Hawaii, and then what is it, 3 there? Anyway, at night. And so this idea of ethics versus just requirements. Now, can carriers and the whole dental benefits world push? Sure, it can. Is that what Carefree does? And when we're talking about CAMBRA, I'm not talking about products again. I'm talking about the philosophy. And the good news, Lisa, Lisa Graziani, I want to ask a question. Lisa, in your dental hygiene program, I don't know if there's any other educators here. If there are, jump in here. What is being taught now in your dental hygiene program? Are they using the CAMBRA philosophies? Has that been integrated into your curriculum?
Yes, it is. It's part of their assessment. It's actually part of their chart. So they have to do CAMBRA with all of their patients. And this book from Dr. Kim, I actually have these books that were donated to us, I want to say 4 years ago. We got a box of like 100. So every year I give every single one of the students this book, this balance book, and it's part of our preventive course. So we're all on board for this. Now we don't code it out or anything like that, but it is part of their chart.
Okay, well, why don't you code it out? Talk about how you do codes in school.
Funny you should ask, Miss Patty. We don't really. We have a basic sheet, a fee sheet with your basic codes, and we're in the process of free coding. Everyone that comes in, we don't bill insurance, but we give receipts to the patients if they'd like to submit to insurance on their own. And so we're actually revamping how we're doing codes. I actually got it passed this semester to put the gingivitis code in. So as I'm implementing the new perio grading system, we're doing an overhaul. So I'll let you know at the end of the summer how that goes.
Okay, Linda, what are you saying there? Go on, Linda Jorgensen, say it.
Well, I'm from Wisconsin, and I also am a retired educator, dental hygiene educator, and program director. And I did try to implement CAMBRA or something like CAMBRA, very CAMBRA-like, into the program, and just incorporate it because I thought it was so well done, and there was a good scientific basis for decision making and patient education and care plans, including preventive care plans, but also treatment care plans. It's like if you have somebody who's at high risk, you treat them differently. Anyway, I got a lot of pushback on, but dental hygienists, and I hate to even bring this up, dental hygienists aren't allowed to diagnose, and this is a diagnostic procedure. And so I know, are you all just like throwing things at your computer screen right now?
I just was clenching.
Clenching your teeth. I'm so sorry. So anyway, it's just like this perpetual argument that we have to make. Honestly, the idea, the statement that particularly dental hygienists, but no one is allowed to make a diagnostic statement except for a dentist. That's logic and reasoning and language that started when the Panama Canal was being built. Please laugh at that. It's like it's 100 years old. Now we know that, we don't do anything unless we think about it first. What am I doing and why? And the answer to the question of why is my diagnosis. So it's just like, please come and arrest me, throw me in jail, and let's have a little trial. And I would love to stand in front of any kind of a jury. Oh, yes, I diagnosed. And here's why I did it, because it's a thought process. You really cannot stop me from making, I don't know. So I just wondered about the educator who was speaking before and said that she incorporates it into the program. Good for you. How'd you do that? And how do you respond to this whole diagnostic business nonsense?
Well, I kind of ignore the diagnostic part of it, and it's just part of the program. It is what it is, and that's what we do. So as far as when they get out of school and they get into an office and it's different, then all I can say is I hope they can make a difference or at least incorporate wherever they end up working. But yeah. I'll tell you, one day I just said, you know what, we have to do this.
Yeah.
And we made our own little, I made our own little form. We don't use the exact form, but it was more like a little formula to help them figure it out with a number system and what the risk is. And that's what they need to do. They need to complete that before they can fill out a treatment plan. And yes. I just said, we're doing it. And I didn't get any pushback from faculty at all.
Good for you.
The thing is it a diagnosis or is this a diagnostic?
Well,
the language thing. Because when we're talking about a risk assessment, it's a diagnostic for which we put together the factors to make a diagnosis.
Yeah. The thing is, yes, you can play some word games and then get away with it, and that's always good. But you know what? I'm 70 years old and I'm getting a little tired of this. I'm just tired. Like, come on.
Amen, Linda. Amen.
I introduced it as a learning tool for the students. And that's the verbiage I chose to use. And I didn't get any pushback from the dentists that are on our staff. And it was just considered a learning tool.
Yeah.
Okay. Anybody have any discussions? Cheryl, you know what? I love what you're saying over there in the Dropbox. I mean, over there in the chat box. So Cheryl, talk about from the Hawaii perspective about our discussion here.
Yeah, when you talk about Caries' risk assessment as a ethical duty, as one of the board members on this state board, I would say yes. Without risk assessments of any kind, we cannot begin to properly care for the patients, let alone develop a treatment plan or a preventative care plan. We had tried to codify the risk assessment, treatment, implementation, recare to reassess again and then modify if we have to, and then referral. So, but I hear their point though, because we got that really watered down. But we have sort of in there, we codified that one of the duties of a dental hygienist is to do risk assessments, which identify dental hygiene needs. Instead of dental hygiene treatment plan or diagnostics, they had watered it down, but we got it to say establishing the dental hygiene care plan, which reflects dental hygiene goals and strategies. And then to implement, we would say, instead of treatment plan, because the dentist really didn't like that word, that the dental hygienist could treatment plan, we put down like providing dental hygiene care, which may include but is not limited to pain management, debridement, care of restorations, modification of behavior, preventive health education and nutrition counseling as it relates to oral health. They took out totally referral because that's the dentist's duty. But yeah, we fought hard about 6 years and we got at least that. So in my view, yeah, risk assessment is definitely a professional ethical duty of the dental hygienist. It starts with the top. We do have to work with a lot of dentists as far as doing coding, proper coding, but we're getting there.
Getting there. That's right. If it's possibly some happens someplace else, it can happen wherever you are. Bree, what do you have to say there about diagnostics versus diagnosis? Bree?
Oh, sorry, I had to unmute. I definitely agree. It's a diagnostic tool, not a diagnosis. An assessment isn't a diagnosis, just like a screening isn't a diagnosis. It's merely a diagnostic tool that we're using, and a risk assessment is nothing more than a diagnostic tool. So any dentist that wants to argue that it's a diagnosis, I think is a little overkill. It's a screening assessment.
Right, because Linda, how did that work with oral cancer, head and neck oral cancer screening? Was that a diagnosis too when you were performing that care?
There's sure, screening is a diagnostic tool. You're looking for signs and symptoms and preconditions for, let's say if I talk to somebody about alcohol consumption and tobacco use and HPV, those kinds of things. If I'm just talking to them, assessing their risk for getting oral cancer, that's what I'm thinking about when I do that. And I'm checking off boxes either in my head or on a piece of paper or on a computer. I'm doing an assessment. It's not diagnosing the cancer necessarily. They may not even, they probably don't have it, but at least they have the risk factors for it. And so I'm going to educate the patient based on that screening about their risk. And even something like that, I have worked with some both hygienists and dentists, like I'm crossing the line. I'm practicing medicine. I heard that about taking blood pressures too. Like, oh my God, you're practicing medicine. So, it's like, come on. Like I said, I'm
even with a diagnosis of cancer, Susan, can you jump in here? Where do we get a diagnosis of cancer? Susan? You still
Say
there,
that again.
Patton?
Say that again,
Well,
Patty.
how is a diagnosis of cancer made?
Well, it's biopsy.
Hello. In other words, a dentist can't make that diagnosis either, can they?
Right. Exactly.
That's the point I'm trying to get to here. This games that happen around diagnosis, diagnostics, and in actuality, what my experience has been over and over, we rarely make a diagnosis in dentistry. We just do stuff. And the codes are the stuff codes that we do. We've brought dentistry down to a commodity versus what we really are, and that is that we gather this data and with our educational background and our best ability, put those clues together to come up with the right treatment plan. But a right treatment plan, there does need to be a diagnosis somewhere, and it needs to be written. So it's a crazy world we live in. I know we could talk a long time. One of the things that I like about the Caries-free system is that it's a system. And again, if you've not ever experienced one of their treating webinars, I really encourage all of you to do it, because wherever you're at, whatever you're doing in your practices now, you will learn something from their learning their 5-step process. Talk about building their protocol as well as their systematic way that they have of implementing treatment. The process, again, assess, test, diagnose, recommend, reassess. Looks a lot like ADPI, doesn't it? Yeah, it sure does. And that's where, again, this process of care and the consistency. That's one of the things that still we have so much variety of how, people can go to 2 different offices and get 4 different diagnoses, okay? 4 different treatment plans. It's crazy. And we need to have more consistency in our dental world, that's for sure. Again, I encourage you, and if you did the poll before, you already have this number, so you can text in and contact them with the information that they asked for there with your name, your practice, the phone number, and an email, and get on this. I know I asked Jenny Wolfenberger earlier this day. You know what, I haven't done one of these for a while. I want to do one again. So I'll be jumping in on a training session with Caries-free. And again, I appreciate Caries-free as one of the companies that sponsor my work, and and the reason I work with them is because of their values, because of the philosophy that they come from, and it's something I believe in. That's the only type of companies that I can work with. Again, I want to remind you and put it on the calendar, Monday, the 20th of May, we will have Anne-Marie. It will be a 7 o'clock start. And we are, again, I appreciate every single one of you making a difference, being here. If you need me in any way, text me, email, Facebook. If you are interested, any of you are interested in leading one of these, one of our masterminds, as you can see, you don't have to really do a lot of work for it. It's just to get everybody to talk. If you're interested in that, you have a blog post, or you have a question. I updated the dental codology website this week, with a couple of the questions. When I get my Q&A that I get from my different courses, I take them and I post them. Some of them I put in the general information in dental codology. Some of them there is a special place in the insiders section. I know many of you have not really taken advantage of that as much as possible. We do have that insiders section. So I like to take this. This is from, again, my friends at Caries-free. And they quote somebody that I really admire, and that's Maya Angelou. And that you do your best until you know better, and when you know better, you do better. And that's their mission, to have a different approach. And it again is my mission also. So we are dental codology. We are charting the future, and I know that we're up to it. We're not going to sit back anymore and let somebody else lead our future. We're proactively leading ourselves and our world into a different future. And I thank all of you for being here tonight, and I wish you a very happy holiday and some time off. And you know what? Eat the candy. It's all fine. Cavities aren't caused by candy anyway. So have a good Easter or whatever your tradition is. All right. Good night, everybody.
Night, Patty. Thank you.
Good night. Thank you.
Good night, Patty. Thank you.